Transformational leadership, it goes beyond transactional leadership to inspire and motivate followers. Transformational leadership emphasizes the importance of interpersonal relationships. Transformational leadership is not concerned with status quo, but with effecting revolutionary change in organization and human service. Whereas traditional views of leadership emphasize the differences between employees and managers, transformational leadership focuses on merging the motives, desires, values, and goals of leaders and followers into a common cause. The goal of the transformational leader is to generate employees' commitment to the vision or ideal rather than to themselves. Transformational leaders appeal to individuals' better selves rather than these individuals' self-interests. They foster followers' inborn desires to pursue higher values, humanitarian ideals, moral missions, and causes. Transformational leaders also encourage others to exercise leadership. The transformational leader inspires followers and uses power to instill a belief that followers also have the ability to do exceptional things. Transformational leadership may be a natural model for nursing managers because nursing has traditionally been driven by its social mandate and its ethic of human service. In fact, Weberg 2010 found that transformational leadership reduced burnout among employees, and Grant et al. 2010 reports transformational leadership positively affected the practice environment in one medical center. Transformational leadership can be used effectively by nurses with clients or coworkers at the bedside, in the home, in the community health center, and in the health organization. Shared leadership, reorganization, decentralization, and the increasing complexity of problem solving in healthcare have forced administrators to recognize the value of shared leadership, which is based on the empowerment principles of participative and transformational leadership from Everett and Sitterding of 2011. Essential elements of shared leadership are relationships, dialogue, partnerships, and understanding boundaries. The application of shared leadership assumes that a well-educated, highly professional, dedicated workforce is comprised of many leaders. It also assumes that the notion of a single nurse as the wise and heroic leader is unrealistic, and that many individuals at various levels in the organization must be responsible for the organization's fate and performance. Different issues call for different leaders or experts to guide the problem-solving process. A single leader is not expected always to have knowledge and ability beyond that of the other members of the work group. Appropriate leadership emerges in relation to current challenges of the work unit or the organization. Individuals in formal leadership positions and their colleagues are expected to participate in a pattern of reciprocal influence processes. Kramer, Schmallenberg, and McGuire 2010, and Waters 2009 found shared leadership common in magnet-certified hospitals. Examples of shared leadership in nursing include self-directed work teams, Work groups manage their own planning and organizing, scheduling, and day-to-day work activities. Shared governance. The nursing staff are formally organized at, at the service area and organizational levels to make key decisions about clinical practice standards, quality assurance and important and improvement, staff development, professional development, aspects of unit operations, and research. Decision making is conducted by representatives of the nursing staff who have been authorized by the administrative hierarchy and their colleagues to make decisions about important matters. Co-leadership. Two people work together to execute a leadership role. This kind of leadership has become more common in service line management, where the skills of both a clinical and an administrative leader are needed to successfully direct the operations of a multidisciplinary service. For example, a nurse manager provides administrative leadership in the collaboration with a clinical nurse specialist who provides clinical leadership. The development of co-leadership roles depend on the flexibility and maturity of both individuals, and such arrangements usually require a third party to provide ongoing consultation and guidance to the pair. Traditional magnet functions. In 1916, French industrialist Henry Fole first described the functions of management as planning, organizing, directing, and controlling. These are still relevant today. However, the complexity of today's healthcare systems make these functions more difficult and less certain. Clancy, 2008. Planning is a four-stage process to establish objective goals, evaluate the present situation and predict future trends and events, formulate a planning statement means convert the plan into an action statement. Planning is important on both an organizational and a personal level, and may be an individual or group process that addresses the questions of what, why, where, when, how, and by whom. Decision making and problem solving are inherent in planning. Numerous computer software programs and databases are available to help facilitate planning. Organization level plans, such as determining organizational structure and staffing, operational budgets, evolve from the mission, philosophy, and goals of the organization. The nurse manager plans and develops specific goals and objectives for his or her area of responsibility. Antonio, the nurse manager of a home health care agency, plans to establish an in-home phototherapy program, knowing that part of the agency's mission is to meet the healthcare needs of the child-rearing family. To effectively implement this program, he would need to address how the program supports the organization's mission, why the service would benefit the community and the organization, who would be candidates for the program, who would provide the service, how staffing would be accomplished, how charges would be generated, what those charges should be. Planning can be contingent or strategic. Using contingency planning, the manager identifies and manages the many problems that interfere with getting work done. Contingency planning may be reactive in responses to a crisis or proactive in anticipation of problems or in response to opportunities. What would you do if two registered nurses called in sick for the 12-hour night shift? What if you were a manager for a specialty unit and received a call for an admission but had no more beds? Or what if you were a pediatric oncology clinic manager and a patient's sibling exposed a number of immunocompromised patients to chickenpox? Planning for crisis such as these are examples of contingency planning. Strategic planning refers to the process of continual assessment, planning, and evaluation to guide the future. Fairholm and Card of 2009. Its purpose is to create an image of the desired future and design ways to make those plans a reality. A nurse manager might be charged, for example, with developing a business plan to add a time-saving device to commonly used equipment, presenting the plan persuasively, and developing operational plans for implementation, such as acquiring devices and training staff. Organizing. Organizing is the process of coordinating the work to be done. Formally, it involves identifying the work of the organization, dividing the labor, developing the chain of command, and assigning authority. Directing. Directing is the purpose of getting the organization's work done. Power, authority, and leadership style are intimately related to a manager's ability to direct. Controlling. Controlling involves comparing actual results with projected results. This includes establishing standards of performance, determining the means to be used in measuring performance, evaluating performance, and providing feedback. The efficient manager constantly attempts to improve productivity by incorporating techniques of quality management, evaluating outcomes and performance, and instituting change as necessary. Nurse managers in practice. Putting nurse management into practice in the dynamic healthcare system of today is a challenge. Organizations are in flux, structures are changing, and roles and functions of nurse managers become moving targets. Titles for nurse managers vary as widely as do their responsibilities. Nurse manager competencies. The American Organization of Nurse Executives, A1, an organization for the top nursing administrators in the healthcare, identified 5 areas of competency necessary for nurses at all levels of management, the A1 2005. Nurse managers must be skilled communicators and relationship builders, having knowledge of the healthcare environment, exhibit leadership skills, display professionalism, and demonstrate business skills. These characteristics intersect to provide a common core of leadership competencies. Staff nurse. Although not formally a manager, the staff nurse supervises LPNs, other professionals, and assistive personnel, and so is also a manager who needs management and leadership skills. Charge nurse. Another role that does not fit the traditional levels of management is a charge nurse. The charge nurse position is an expanded staff nurse role with increased responsibility. The charge nurse functions as a liaison to the nurse manager, assisting in shift-by-shift coordination and promotion of quality patient care, as well as efficient use of resources. The charge nurse often troubleshoots problems and assists other staff members in decision-making. Role modeling, mentoring, and educating are additional roles that the charge nurse often assumes. Clinical nurse leader. The clinical nurse leader is not a manager, per se, but instead a lateral integrator of care responsible for a specific group of clients within a microsystem of the healthcare setting, AACN 2007. The CNL role is designed to respond more effectively to challenge in today's rapidly changing, complex technological environment from Harris and Russell of 2009. Prepared at the master's level, the CNL coordinates care at the bedside and supervises the healthcare team, among other duties, from Sherman of 2010. Use of the clinical nurse leader positions in healthcare organizations has improved patient outcomes and reduced costs and is expected to expand as the demand for quality continues. Hicks, McKeon and Walters, 2009, Stanley et al., 2008. Problems have emerged, however, as CNLs transition into organization. These include being drawn into direct patient care, explaining the role to other nurses and healthcare providers, and acceptance by the staff. Sherman of 2010. Questions about the differences between a clinical nurse specialist and the CNL are also raised. While the CNS is assigned hospital-wide, the CNL is unit-based. Ignatius 2010 suggests that hospitals are designed for the 19th century with little accommodation for the coordination of care needed in this century. CNLs can help bridge that gap. Followership, an essential component of leadership. Leaders cannot lead without followers in much the same way that instructors need students to teach. Nor is anyone a leader all the time. Everyone is a follower as well. Even the hospital CEO follows the board of directors' instructions. Followership is interactive and complementary to leadership, and the follower is an active participation in the relationship with the leader. A skilled, self-directed, energetic staff member and an invaluable complement to the leader and to the group. Most leaders welcome active followers. They help leaders accomplish their goals and the team succeed. Followers are powerful contributors to the relationship with their leaders. Followers can influence leaders in negative ways, as government cover-ups, Medicare fraud, and cooperative law-breaking attest. The reverse is also true. Poor managers can undermine good followers by direct and indirect ways, such as criticizing, belittling, or ignoring positive contributions to the team. Arnold and Pulich, 2008. To counter such behaviors, you should note incidents that you experience, enlist others to help, and remain in control of yourself. See Chapter 21 for more about handling difficult problems such as bullying. Miller 2007 describes followership along two continuums: participative and thinking. Participation can vary from passive, ineffective follower to active, successful follower. Thinking can fluctuate between dependent and uncritical to independent and critical. Courage to be active contributors to the team and to the leader characterizes the effective follower. What makes a successful leader? Leadership success is an elusive quality. Some people seem to be natural leaders and others struggle to attain leadership skills. See how one nurse leader described her work? I believe that the most important role of a nurse leader is to live the life and exemplify at all times the qualities that every professional nurse leader should. I also believe that the nurse leader manager must be the person to set the bar high and perform at the highest levels in order to inspire their staff to achieve the same. As a nurse manager, I at all times work to be an excellent communicator, compassionate, caring, vested in my job, willing to go above and beyond and assist people with any task or issue that they need a little extra support on. I feel by doing this, there is never a question what I expect from them and those around me. I verbally set expectations, but by living them as a role model. For example, at shift change, 2 nights ago, a physician wanted to do bedside procedure. I was actually planning on leaving soon after a long day. I knew it was shift change, and I didn't want staff to be interrupted, so I volunteered to stay and do the procedure so they could continue with report, and the physician and patient were not kept waiting. The staff were very appreciative, but more importantly, I think it set the right example of teamwork, being flexible, being patient focused, etc., etc. I think it is important for the nurse leader to provide feedback at times other than evaluations. The nurse leader should schedule time into the work week to have informal conversations with staff on the floor about comments a patient or coworker has shared, or to send an email to a staff member about feedback the leader has received. I think constructive feedback needs to be timely and supportive, and the need for improvement discussed long before an evaluation. I find having conversations about what are your goals or what can I help you explore? Do you have, um, what can I help you explore or that you've been dreaming about to enhance your nursing career? People need to feel comfortable about having these conversations with their trusted nurse leader. Building relationship with those you lead is important. Leaders are skilled in empowering others, creating meaning and facilitating learning, developing knowledge, thinking reflectively, communicating, solving problems, making decisions, and working with others. Leaders generate excitement. They clearly define their purpose and mission. Leaders understand people and their needs. They recognize and appreciate differences in people, individualizing their approach as needed. That concludes our lecture, Week 1, NUR 491, Part 2. Thank you all for your participation. Thank you all for your patience, and I will see you in Week 2. Email me, text me, call me. Any questions, please feel free to ask. And don't forget to relax and drink your tea. Thank you. Have a great week.